Welcome to week 8. Our lecture series on the spine and pelvis continues this week with this two-part lecture series. And in this week's lectures, we are focused on chapter 18, which is dedicated to understanding the structure of the hip and some of the unique features that may contribute to developing a rehabilitation program with sample exercises provided as well. So with that being said, we will get started. There are, as always, a few objectives that go along with the chapter. So in this case, here are a number of objectives for this week. Everything from understanding the mechanics to understanding the different types of exercises and modalities that go into rehabilitation of the structures surrounding and supporting the hip as well. So just to start off with a brief introduction. So the hip is a stable joint with extensive range of motion in 3 planes. As you may recall, the socket is quite deep and reinforced with strong ligaments for stability. As a result, when you compare the ball and socket type joint of the hip relative to the shoulder, the hip has much greater stability. It is much more likely that one would dislocate their shoulder because of the shallow ball and socket type joint in the upper extremity compared to the hip. Now, strength and motion are important for the hip because it serves as a force transmitter for both lower and upper limb activities and provides motion and strength for being able to execute propulsion during activities of daily living like walking or running. Notably, the hip, as a result, will suffer repetitive microtraumatic type injuries, and it is also a common site for pain referral as well. And as I mentioned, hip stability plays an important role when we think about force transfer along the kinetic chain. So next we're going to move on to some special rehabilitation considerations. So a rehabilitation program for the hip should be based on the anatomy of the hip, so the bony structures or osseous structures, as well as the neural structures, mobility, and mechanics. One must also be familiar with methods for reducing stress in an injured hip as well. So let's start off by looking at the bony structures and their alignment, as that has implications for rehabilitation. Firstly, we have the acetabulum, or the hip socket, and that is in an inferior and anterolateral type position. What you can see on the diagram on the far right of your screen is that in normal cases, the femoral neck forms a 125-degree angle with the femur, or the long bone or shaft of the femur, as you can see in figure 18.1 and specifically diagram A. That would be the normal joint angle, but what you can see is that sometimes the femoral neck angles can either be greater or less than the predicted or normal angle. And so because the femoral neck is rotated from the plane of the femur's long axis, the neck and the femur do not lie in the same plane. When we have increased angles, that is referred to as the coxa valga, and that results in increased joint stress. Whereas coxa vara refers to decreased angle below the 120 degrees. And that leads to an increased load on the femoral neck. Now, as you can see in the diagram on the far right of your screen, I was referring to the alignment of the femoral neck with the long axis of the femur. And as I was saying earlier, they do not lie in the same plane. Normal alignment places the neck in a position that is rotated slightly anterior to the femur's frontal plane in an adult, approximately 15 degrees. If this angle exceeds 15 degrees, then we can say that the femur is positioned in medial rotation. This is also known as anteversion. An anteverted hip has more range of motion medially and less range of motion laterally. Conversely, if the femoral neck's position is less than 15 degrees to the femoral long axis, then we refer to it as retroversion. And retroversion occurs to position the femur in more of a lateral rotation. This is less common. So anteversion and retroversion also have significant clinical implications when it comes to the knee alignment and change the forces acting through the lower extremity. Specifically, if we focus in on anteversion as it is more common, this leads to medial hip rotation, foot adduction, and causes the individuals to have what we refer to as a toe-in type gait. Anteversion and having coxa vara, or that femoral neck angle being less than 120 degrees, both of those factors make the hip more likely to dislocate. Now, you can also measure anteversion, and that can be done commonly with what's known as Craig's test. It is performed with the patient lying prone and the knee flexed to 90 degrees. The rehabilitation clinician can move the patient's thigh into medial rotation until palpation or till one palpates the greater trochanter and reveals that it is parallel to the tabletop. Then the joint angle can be measured, and it's really the difference between the tibial position and drawing an imaginary line vertical to the tabletop. And so this will represent the degree of anteversion. Craig's test for femoral anteversion is also shown in your textbook. This next figure really just highlights the normal alignment and how it normally places the neck in a position that is rotated 15 degrees anteriorly to the femur's frontal plane in an adult. Next, As I was mentioning from your textbook, here is a diagram showing you how you can actually assess for femoral anteversion. And once again, you can see the greater trochanter is positioned parallel to the tabletop, and the angle between the tibia's position and 90 degrees of knee flexion at this point and a vertical line is measured. Now let's go on and look at additional special rehabilitation considerations. So we've talked about the bony or osseous type structures and how that may impact rehabilitation. Now if we move on to the neural structures. So we have the sciatic nerve, the lateral femoral cutaneous nerve, and the obturator nerve as well. And the nerves entering the entire lower extremity must pass through the hip region. Nerve irritations can occur when soft tissues that surround the hip actually impinge on the nerve. As an example, the sciatic nerve passes below the piriformis muscle and through the sciatic notch and extends down the posterior thigh. Entrapment of the sciatic nerve can produce irritation distal to the site of entrapment. Next, a sensory branch of the femoral nerve, known as the lateral femoral cutaneous nerve, travels through the psoas major muscle and passes under the inguinal ligament near the anterior superior iliac spine. Compression of the lateral femoral cutaneous nerve can cause aching and burning, particularly on the anterolateral side of the thigh, where the nerve provides sensory innervation. So this is near to the tensor fasciae latae. And then finally, another example of a nerve would be the obturator nerve. And the obturator nerve passes or enters the pelvis and provides sensory and motor innervation to the medial thigh. And so this can cause sensory changes and adductor weakness when you have entrapment of the obturator nerve. Next, we should also consider stabilization of this region. The hip muscles are important when we think about power of the lower extremity and the associated kinetic chain. If the hip muscles are weak, not only will less force be applied, but there will also be additional or excessive stress in the body to compensate for weak hip muscles and their inability to provide the needed forces. The hip must be the platform from which the pelvis functions, and as a result, hip stability is crucial, similar to how trunk stability is crucial as well. Next, moving on to joint mechanics. As I've mentioned, there is an interaction or a connection between the pelvis and the hip. An anterior pelvic tilt moves the anterior pelvis closer to the anterior femur, and a posterior pelvic tilt will do the opposite action. This change in the pelvis alters the hip such that that anterior pelvic tilt increases hip flexion, whereas a pelvic tilt posteriorly will increase hip extension. This has implications when examining a patient and looking at their posture. Furthermore, when we think about the body's center of mass, it can shift towards the supporting limb when a person moves from a two-limb to a one-limb stance. As shown in figure 18.4, you can see the single limb stance mechanics. Essentially, the hip becomes the fulcrum from which the pelvis drops towards the non-supporting side. Normally, the stance limb and the hip abductors of that limb have enough strength to pull on the pelvis so it remains relatively level or stable during the single limb stance. The weight transfer will place stress on the weight-bearing hip because of gravity and gravity's pull on the non-weight-bearing limb. To minimize pelvic drop that occurs on the non-weight-bearing limb, the abductors, once again, on the weight-bearing leg need to work to keep the hips level. Notably, cane or crutches can be used on the side opposite the weakness. And what this does is it allows for an upward force to be transmitted through the cane or the crutch to offset the gravitational force on the same side. Patients who are using a cane or a crutch in the hand that is opposite to the lower extremity injury, therefore need to apply just a light pressure to offset that gravitational pull and to compensate for any weakness in the abductor muscles. Lastly, when we think about joint mechanics, individuals can have leg length discrepancies for a number of different reasons. So, for example, could be due to coxa vara, could be due to a rotated sacrum or foot pronation. It could be soft tissue pathologies as well, such as hip flexor tightness or abductor tightness and muscle imbalances. Now, this can have long-term implications for the development of osteoarthritis, particularly in the side of the hip that has the longer limb. So when there is that leg length discrepancy, osteoarthritis can present. And this occurs because the longer limb is in a position of adducted angulation when weight bearing, thereby producing incongruence within the joint and leading to greater body weight shifts towards the shorter limb. As a result, there is an increased compressive force acting on the longer limb's hip joint abductors and placing further demand on them to keep the pelvis level. So once again, it is leg length discrepancies that can lead to osteoarthritis, particularly in the side of the hip that has the longer limb. And that's due to these compressive forces that are acting on the longer limb's hip joint abductors, and therefore they must compensate to try to keep the pelvis level. So once again, uh, cane or crutches can be are appliances that can be used or assistive devices that can be used in individuals where weight bearing is permitted to allow for a normal gait. If the hip is painful, joint stress can be reduced by shortening the stride length when walking or running. A smaller stride will reduce the force and the motion demands on the soft tissue. And that concludes this first lecture episode.